Again, you're learning different perspectives today. It's interesting how healthcare is a topic. We see it from an academic perspective, providers looking at it, and obviously as purchasers, we've been doing a lot of amazing things. As CalPERS, many of you knew we were leading the way. And Jackie Robinson may not realize it, but I'm aware that he was one of our biggest critics when we were doing reference pricing. When we looked at cost variances, we were doing hip and knee replacements. There was $10,000 at one hospital, $110,000 at another. And we were told by economists that we could not fix the price at $30,000. But now, fast forward many, many years later, and we have done an amazing job. So with that, I'd like to introduce our panel today. We have Dr. Kathy Donneson. She is the division chief over the Health Plan Administration Division. She has been pivotal on benefit designs, including the hip and knee that I just mentioned. Plus, she just added 12 new procedures to our reference pricing model that will be effective in January. She is also a retired colonel from the Air Force Medical Services. And so it is an honor and a pleasure to work with her on her team. And then we also have John Prince. He is the CEO of OptumRx at UnitedHealth Group. We have Phil Jackson, who is the CEO of Health Plan Products at Sutter Health. And Doug McKeever. Many of you are aware that I am his, I guess your successor, I guess. So he, everywhere he goes, I jump. So him and I worked at Youth Authority, but we passed each other, and then we worked at CalPERS, and now he's at Cover California. So he is the Chief Deputy Executive Director of Cover California, and obviously work very closely with David Lansky. He's the CEO of the Pacific Business Group on Health. So please put your hands together for the purchasers panel.
Thank you, Leanna. Welcome, everyone. We are all purchasers. I'm Kathy Donneson, as Leanna said, with California Public Employees Retirement System. And together, I think the gentlemen next to me represent most of the Californians that are covered through some type of individual, large group, or small group practice. I would also like to say, not here, but also a big purchaser is Department of Healthcare Services. And through Department of Healthcare Services, CalPERS, and Covered California, we represent nearly 40% of the healthcare purchasing that happens in California. So we have a new organization called Smart Care California, and we're working together collectively to attempt to continue to push the envelope on access, affordability, and quality. I want to thank Jamie for orienting you to what is reference pricing. That means that I don't have to do that. I also want to thank the provider panel, because without providers, we wouldn't be in business. So I really want us to think about the physicians, the nurses, the ancillary service workers. That's where healthcare is delivered, and that comes from my military side, where we used to deliver combat medicine services across the globe. So having said that, I do want to tell you what my new initiative is going to be. It's really looking at value-based insurance design, redesigning benefits so that we are channeling care or guiding care to high-value performing purchasers. We're also looking at overuse, underuse, and misuse of services. So while we've talked about reference pricing directing our members to lower cost while quality and patient safety is held constant, the next frontier for us is it necessary? So that's my 5-minute commercial for CalPERS, and now I'm going to turn it over to John Prince, who's going to talk about pharmacy benefit management. Give us a glimpse into the black box of pharmacy benefits, maybe talk a little bit about the need for transparency, and also what's happening with the manufacturers. John?
Thank you. Today, so just a little backdrop on OptumRx. OptumRx is a pharmacy care services provider. We serve 65 million people, and we also handle 80 billion of drug spend. So we actually manage that, as well as a specialty provider in infusion therapy. What I want to talk about was really 4 things. One is, what are the drivers, from my perspective, of the issues around pharmacy? 2 is a little perspective on transparency. Third is a little better perspective about pharmacy care services and what is the value provided from it. And lastly is a perspective from OptumRx. So as you look at the pharmacy care services space and what are the drivers for it, I think that my predecessor panelists have talked a lot about what the key trends are. I'd probably highlight 3 things that is driving the national agenda right now on a federal and state basis. The first one is the increasing price of drugs. So if you look at the price of drugs last year, it was up about 10%, and it varies by different categories. That trend, combined with the fact that now 40% of the commercial market is in a high deductible health plan, means that those individuals, 40% of America, now cares about the first dollar coverage of pharmacy costs. So they prior had an issue around co-pays or other small amounts, but the fact that now with increasing drug prices and 40% of the market caring from a commercial standpoint, that's creating a lot of pressure in the broader market around drug costs and what's the affordability of drug costs. The third and final trend I think is critical to it is transparency. And the focus in the industry around, in the whole supply chain around pharmacy is trust and transparency. And my second comment I want to do is actually define that, because I think that is a term that's put out there a lot, and it means different things for different audiences. So when I think about transparency, I think you got to think about it from 2 perspectives. One is the client, or the person paying for it, and the second is from the consumer standpoint. So if you look at from a client standpoint, the client is looking for full visibility into the entire supply chain economics about where is rebates, what is manufacturing fees, what are all the things that are being passed on to them. The second thing they're also caring about from a client standpoint is what is the actual net total cost of the drug. So when you actually look at our arrangements with our clients, that's actually how we do business. So the lady to my right is a client. As you look at that, we actually give complete supply chain economics to our client in terms of actually how the drugs are purchased to a net cost level. The question on transparency is more at the consumer level. With now 40% of the market being effective from $1, the consumer has different expectations. Do I understand what's covered? What is it going to cost me? Should I have covered under drug A or drug B? What will the cost differences be between that? All those types of, I want a simple process. That is where the gap is in the market today around transparency, which is, are we giving the consumers the tools that they need in order to support that? Another area around transparency is around, is there a pay for play? And how you actually get on a formulary. And I'll actually just tell you what is our formulary process, because sometimes, even though we talk about it, people don't always hear. And so our formulary process is open and transparent. So our Pharmacy and Therapeutics Committee meets every quarter. It's an independent group, nationally based, broad-based mixture of pharmacists, physicians. They actually go through a very rigorous process that looks at academic research, looks at the evidence about different therapies, both existing, future, and then makes a decision, should this therapy be on the formulary? So that is a completely independent process. Our process is actually live streamed. There's a screen that actually shows what is actually happening in these rooms, as well as the evidence-based. That is the actual process of actually how you get on the formulary for OptumRx. There's a separate process than actually negotiating once you've actually said it's something on the formulary of how it works, but that's actually the process. And so I just wanted to start clearing up some of the misconceptions about actually how transparency works in the space. Third area I want to talk about is around what is the value of pharmacy care services, and we really focus on 2 key things. One is actually driving value for our clients around the cost, and the second is around making health and health outcomes better for everyone we serve. And these are independent studies. I'll just quote around the value is that last year we drove about $128 billion of lower cost in the pharmacy care services space because of the negotiations we did. CMS actually came out with Part D in terms of negotiations in 2015. That Part D would actually be $24 billion more expensive actually, but we didn't have PBMs negotiating as part of that. So part of it is actually negotiating with pharmacy. The other part is actually negotiating with retailers. So the actual price that we pay a retailer is 57% off their actual cost. So our job is to take those 2 economics and then give complete transparency to our client that hires us about what those economics are. The second big thing that we focus on is the value we drive, which is around outcomes. So last year, these are independent studies, that 100 million of the pharmacies that were written in the country were actually changed or prevented because they would actually have had a drug-to-drug interaction or drug-disease interaction. And in our own book this past year, that would have actually, we drove $1 billion of value to our clients, as well as avoided harmful things to our patients that we serve because of that. And that just gives you an example around the value that we drive in the organization. So with that, I'll turn it over to my next panelist.
And I would like to introduce somebody that I am just started to get to know. That's Mr. Phil Jackson. And before I have Phil make his presentation, I wanted to tell you that every single panelist up here, we've spent decades being passionate about healthcare, whether we were in a provider role at one time or a purchaser role at one time. And one of the things that really struck me about Phil is his passion for not just the new health plan that he's going to be operating through the Sutter Health System, but his passion for integrated care in a provider-driven world, and with some new things that are coming for Sutter around risk-taking. Phil also, I found out, knows Ellen Nelson of OptumRx because they worked on the co-op together in Oregon. And so I would like to now turn the next part of the presentation over to Phil.
Thank you, and thanks everybody for having me here today. I feel very fortunate to sort of sit amongst, I think, some of the greatest thinkers in healthcare reform today. So this is a great opportunity. I've been in Northern California with Sutter for 8 months. I wish this onboarding had occurred a little earlier. So the first thing is, I'm a little bit provider and I'm a little bit payer, right? So you could put me in either panel. So I live at that intersection, much like Kaiser does, of care and coverage. And that's the combination, what I would describe as the dynamic tension between the financing and the delivery of healthcare. What I find invigorating for me personally, and I think I share this passion and interest with the CEO of Sutter, Sarah Krevins, is that tension creates energy. And if we can harness that energy internally, that's what's going to drive the transformation of healthcare. We've, for the most part, as a country, have focused on health insurance reform. I think, as was described earlier, we've sort of set the stage for healthcare reform. But from our perspective, in order to do that effectively, we need to be accountable for the total cost of care. And in taking on that level of accountability, that provides incentives for us to be creative about how we care for patients. It provides rewards for the innovation that we really believe is going to provide better care and better health outcomes. And as you heard earlier, it'll be less about whether or not there's a CPT code I can submit to get reimbursed for this service or this intervention. And it's more about what's going to meet the patient's needs, what's going to provide better access, better affordability, a better member experience, better quality care. So from our perspective, being in a position of bearing risk and growing in our responsibility for risk-taking and risk-bearing is beginning to look at the care model redesign. So we're taking very seriously the fact that, you know, what one of my previous bosses described as the tyranny of the office visit. So the only way you could get healthcare in America was either to go to the ED or get on your bike or your car and go to the office visit. It didn't matter whether your level of care needs match the intensity of service that was being provided in that care setting. That's where we made you go. So our investments right now, in large part, have to do with creating more access, more doors, more affordable points of entry, working on sort of the clinician mix. You've heard practicing to the top of your license. These are all sort of enabling elements that we think are going to be a key part of affordability and the transformation of healthcare. The other piece that I think we need to spend a little more time and energy on, because for those of us that have lived in the managed care of the 90s and sort of saw capitation come and go, one of the things that was really apparent was we could only put so much risk and so much responsibility on the delivery system, although we have a lot of responsibility and accountability to improve our service, our affordability. But at the end of the day, we have to find more effective ways to engage our members, our patients, our communities in their care, and to find ways to activate them to be engaged and care about their behaviors their life choices. I think we have to be more effective in providing education and information. So it's not just about the cost of your treatment choices, but for those of you, again, who've been in this business for a while, we used to spend a lot of time talking about the preference-sensitive conditions, right? Where there are choices, not just cost choices, but there's quality of life choices that we don't do a good job of engaging and activating our patients and our members in. So I think there's a lot of heavy lifting to do on the transformation in healthcare. From Sutter's perspective, owning our own commercial HMO product, entering into a joint venture with the Aetna on sort of the self-funded and insured PPO products are going to really sort of create a flywheel that we can build off of as we continue to increase the number of contracts and lives that we have, not just under value-based care, but capitated and full risk arrangements.
Thank you. As I introduced my former colleague and current colleague, because Doug was my counterpart, then he was my boss, and now he's my colleague, I do want to speak a little bit about Covered California, because CalPERS is a large group purchaser. What Phil has talked about is how they're looking at maybe smaller group markets and making sure the small group is covered in terms of access and affordability. Doug has the interesting role of having to deal with an individual market. And in addition to having to sign up individuals, Doug also has a footprint between Washington, D.C. and California. And so that's a big lift. And I just want to reassure Doug that I know what he's going through with the individual market, because I also sell long-term care insurance, and that's a tough sell because you're really paying for the cost of care. So Doug, would you please take it away and discuss the challenges faced by you and the Covered California organization?
Thank you. Wow.
Everybody's awake now.
Thank you, Kathy. And now everyone is awake. I don't know if it was a good idea to put our pictures in this thing in front of us, because I just noticed I'm wearing the same thing I am when I took the picture. I do have other ties, but clearly I chose to wear this one today. I want to, before I get into the whole Covered California piece, I want to ground us in some realities, and I think a lot of us have already nibbled around the edges on this, about not forgetting who we serve, the patient. I'm wearing a bracelet right now for someone who's a dear friend of mine who's going through breast cancer. And it's just a reminder for me, not only for her, but I think for all of us, let's not forget who it is that we are here to serve. Because at the end of the day, everything we're talking about is for that patient. With that in mind, we're lucky. We have 1.4 million members in California who are with Covered California. We do have a Covered California for small business, 30,000 folks. Not going to talk about that today. But we have been a success in California, despite a lot of the rhetoric that has gone on throughout the country over the last 6 to 8 months. A lot of that success is due to how Covered California was set up, and how we operate, and how we will continue to operate into the future. Secretary Dooley mentioned something that I think is worth reinforcing, which was before the ACA in California, the uninsured rate was about 17%. And now we're down to 7%. And as she indicated, it's actually less than that if you take away those who are not eligible to be enrolled in the market. That is a phenomenal effort that has gone on and should be applauded on a regular basis relative to what California has done to decrease that uninsured rate. Now, working on the commercial side prior to Covered California, guess who paid for those who were not insured prior to that, right? We don't want to go back to that. The commercial side has been blessed, if you will, over the last probably 4 to 5 years with pretty doggone low medical trend. I'm not going to talk about pharmacy trend too much, John, but on the medical trend side, certainly it has been a pretty decent trend line over the last couple of years. And I think a lot of that is attributed to that uninsured rate going down so much. So what has our focus been? And I really want to talk about some of the things that we've done that have allowed us to achieve that affordability criteria. And I will say that for us, this is critically important because, as Kathy mentioned, on the individual market, these are folks that we're serving that have a really difficult time financially making ends meet. Yes, they get subsidies from the federal government to help assist them, which in most cases are necessary. And in fact, 90% of the 1.4 million members that we serve receive a subsidy. So it's a large amount of individuals who need that financial assistance to get through. But in order for it to be successful, one of the things that we've set up are areas that have really, I think, helped shape and move the needle on the provider side. One of those is primary care. I haven't heard anybody talk today about primary care and the fact that primary care is a critical component of the healthcare system. Recently, Covered California made the decision to have every single one of those 1.4 million consumers have what we're going to call a health advocate. It's not a gatekeeper, but 99% of our members today are assigned a doctor that they can use as their advocate to help them navigate through the system. Now, I'm going to guess as we do the research on this over the next couple of years, we're going to find that by doing that, we are helping shape the affordability curve. And we're increasing the health of those individuals because of that PCP assignment. The other thing that we're doing, and this was touched on by Kathy with Smart Care, and this is where I really think purchasers have an ability to leverage and assist and guide and coach the system, and that is consistency. During my time at CalPERS and my time now, being part of PBGH and IHA, I can't tell you the number of times that purchasers and providers consistently scream for consistency. And that's one of the things that's driving some of the issues that we're dealing with today. Some of the things that we're working on now that have already started to bear fruit are maternity. Having consistent expectations of C-section rates in California by the hospitals is already bearing fruit and showing positive returns. That is an area in which that collaboration has greatly helped the system as a whole. Accountable care organizations, they're everywhere. Everyone's got their own definition of what one looks like. What does that integration mean? Well, we're working right now with Suzanne and CPR and IHA, CalPERS, Covered California, to come up with a standardized ACO measure set. That is a huge step forward in how we can all collectively look at what we're measuring, how we're measuring it, why we're measuring it, ultimately, again, leading to better, efficient care and hopefully addressing that affordability curve as well. I think what I'll do is stop there and only leave you with the fact that part of our efforts at Covered California include contractual relationships with the 11 carriers that we work with. And Secretary Dooley made the term partner, and I'm going to continue to use that term because they are our partner in this effort. Those contract provisions that we have in what's now known as Attachment 7 are vehicles by which they're a gift. They're a gift for CalPERS, they're a gift for us, or a gift for others to use so that the system as a whole can be consistent. And again, I'm going to keep using that word, but I think that's really where we all need to go to increase the efficiency of care at the local level so the patient who goes into care gets the care that they need when they need it, and we then also deal with the affordability curve.
Thank you, Doug. Before I move on to our last speaker, Dr. David Lansky, we haven't really talked about high deductible plans and the burden that it places on the member or the families in terms of meeting that higher cost share. So as CalPERS looks at dealing with channeling or guiding our members to evidence-based care based on value and evidence, we may be looking at varying cost shares in terms of those that want to continue choice in terms of an open PPO plan versus those that are willing to engage with the provider community to follow the evidence and to seek high-value care. So that's part of our direction. I want to speak a little bit to the private companies in the audience, and there are some that David doesn't have as a membership. I do want to speak to them that as you look at how you structure benefits, look, I would say, towards value versus premium savings through higher deductibles. And so now I'm going to turn it over to Dr. David Lansky, who's going to talk about whether care is even affordable any longer, and talk about the private sector payer community and how they view the challenges that we face in terms of affordability. David?
Thank you, Kathy. Good afternoon, everyone. I'm pleased to be here. Very happy to be here with some of my members. Both Covered California and CalPERS are members of PBGH. And for those of you who don't know us well, we have about 60 members. They're mostly private employers, large national employers like Walmart and Boeing and Intel and Comcast, and a number of important California players like CalPERS and Covered California and UC. Together, they represent about 10 million people. And they all share the same concerns about value that we've been talking about all day, and the value of healthcare and the affordability of it for their employees. And so I want to, I guess, to your last point, Kathy, begin with the premise that while they are continuing to pay for healthcare at its current cost, they don't really think it's affordable anymore. And certainly for their many employees, it's not affordable. If you put yourself in the position of someone who works at a Walmart or at Disney as a very modest income, modest job, more than a third of your total compensation is going to us, not to your family, because that's how much transfer of wealth we're incurring on the behalf of American workers to the healthcare system. The premiums and the total costs and the out-of-pocket costs are just really exorbitant. Most of my companies are international, so they do watch closely what's happening to international prices and costs, and they see that we are spending about 55% more per person than any other place they have employment. They are increasingly not hiring people in the US because it's so much cheaper to hire them somewhere else for lots of reasons, but healthcare is one of them. So Warren Buffett recently said famously that healthcare costs is the tapeworm of the American economy. It's a very serious problem for American business, and they don't see us doing really very much seriously to address it. We've heard today about a lot of very worthwhile initiatives that we are part of and we support and we try. And one by one, we all try these things. I'm just publishing a blog next week that has 10 reasons why costs are so high in the US. And so there's at least 10, there's probably 40 reasons that we've all talked about why they're high. And there are probably 50 strategies we've talked about today, from digital health to bundled payments to comparative effectiveness research and all the rest. But if you look at the sweep of the last 20 or 30 years, how much have we really dampened the price curve? And how much are we dampening it now? And how much are we approaching international comparability of what we're spending on healthcare? And I think the answer to those questions is not very much. So it's not highly credible to me that continuing to beat on the same tools that we've been beating on the last 10, 15 years is suddenly going to hit a tipping point of transformation in the health system. Something else is going to happen to make that process change. Our view at this point is that it's an ecosystem problem. It's not a problem of which lever does Comcast pull or Walmart pull to somehow achieve affordability for their employees and better care. And I'll tell you, many of my members are extremely concerned about the quality of care they're getting. One of my members has begun a second opinion cancer overread service for all their employees who are diagnosed with cancer in the local community, and 40% of the cases are recommended for reevaluation, different treatment protocol. They don't have cancer, or the staging is wrong when they're reread by a Mayo Clinic or Sloan Kettering team. 40%. So if you're a large employer and you're paying enormous amounts of money for cancer care in the community, and you get back feedback from very credible professionals saying 40% of what you're paying for is inaccurate and leading to wrong care, that's very troubling. So those folks in these companies are not interested in perpetuating the status quo or tweaking a percent of gain sharing here or there on an ACO formula. It's got to be a much deeper analysis and response to the problem of affordability to engage these companies in the process. So I think Diana said very helpfully at lunch, one pathway is, in the world that she works in, to really focus on how do we get alignment by the purchasers, public and private, Medicaid, commercial, Medicare, on a set of requirements and expectations that are transmitted to the health system. Like any buyer of a product or service, at some point the buyer has to step up and say, we're going to pay for this, we're not going to pay for that. And that has not happened very much, and purchasers have been correctly accused of not having much backbone and not adopting the kind of rigorousness to their supply chain that they do in every other part of when they're building cars and computers and whatever else they're building, they are not holding us to account the same way that they're holding other suppliers to account. So at this point, our focus is really on how do we find opportunities for collective action. I think Doug just talked about that. Secretary talked about that. We are certainly appreciating that. The Attachment 7 document that Doug just mentioned, Lance and Doug just came to the board meeting of all the PBGH members just a week ago and basically invited all the commercial companies to use Attachment 7 as a template that they can also use to create action in the market around a set of quality expectations and requirements. And there's a really positive response to that, whether in primary care or other elements of the model. We're also thinking about the market itself and how to reduce the dysfunction of the market. And the path that we're talking about there is if you look at a community that has a reasonable number of organized care systems, and I know, Alan, this will go back to the work you've been talking to us about for decades. At some point, we need to have real competition between organized systems against a set of meaningful criteria. Now we would call them outcomes-based criteria. Total cost of care and health outcomes, and having organizations like Kaiser, like Sutter, like Canopy, saying that they are going to compete with each other on price and quality, and have a transparent public competition where the terms of that competition are determined by the patients and the purchasers who represent them. So we're looking for markets where we can do that. And the belief there is if we can create meaningful competition at that system level, that will create downward pressure on prices. People will have to compete to attract business in a way they haven't up until now. And ultimately, with the American health system, if we don't tackle price, we're probably not tackling the root causes of affordability. And we haven't had many mechanisms to really get at price. Hopefully, real competition between systems of care can get us there. So I will stop there and look forward to the discussion.
Thank you so much. And I was going to give them 2 minutes for this one question to answer, but I'm going to give them 1 minute. So, and they're prepared. The conference today has given us challenges and ideas for the future. I look back where I was 5 years ago and where I am today, and the landscape has changed, and I believe I helped change that landscape with our CalPERS board and our CalPERS team. So I'm going to ask each of you to quickly say, so that our NCHC partners have something to take back to Washington, thinking about our experience collectively, what strategies do you think are actionable over the next 1, 3, and 5 years? And we'll start with John.
Great. I think we're all in agreement that it's around the whole system working together. I think that's at the core. I'd say 3 quick things. 1, for specialty drugs, that actually goes to a value-based outcomes result versus how much you can market. 2 is that if you look at consumer, that the consumer is at the core there. There's so much we could do to actually bring the consumer to the market with the tools. They don't know what's covered, how it's covered, what's the cost, where to go. And that's on us in the industry to actually solve those. And I think those are actually could be solved in 18 months. And then lastly, I think the incentives need to change around all the different components in healthcare.
So I want to, first of all, just sort of piggyback on David's comments. I think we're all in favor of competition, defining what success looks like from the consumer or the purchaser's perspective, and putting the systems at risk to charge towards that goal line, I think is a very effective and meaningful way to move forward. The other thing I'd say that I have not heard yet today is the integration of behavioral health. So I think we've talked about social determinants, but there's a space in between what we're managing and what we're trying to coordinate and integrate today. For the most part, health plans, and to many, in many respects, health systems, have sort of set behavioral health aside. In order for us to, I think, make a meaningful difference in the health of the populations we're serving, we have to be more effective at addressing the behavioral health issues of our enrolled populations. And my last comment is, I just want to know, Doug, if that was the same tie, were those the same socks?
I'm not telling. Mine is easy. I already mentioned one, and that's don't forget who we serve. I think if we keep that focus in mind all the time, then we will get to the end result of where we all want to get. 2, collaborate. there is a lot of these meetings that we all go to, and there's great discussions, and then we go home and we get buried in the work in which we have to do on a daily basis, and we never seem to get to the actual implementation. So I just challenge everybody in this room, the collective wisdom and thinking that is in here today, to collaborate and implement, because I think that's when we're going to start to see this thing generate into some results.
I think short term, we should agree on one thing, that we can do a laser shot and demonstrate success at the collaboration and things we talked about here. Maternity care is a really good one because it touches both public and private. It's not very complex, and we could make a big improvement in that arena by working together. Secondly, I think moving toward outcome measurements for the reasons John and others have said, and getting a foundation and infrastructure for capturing patient-reported outcomes and clinical outcomes is a midterm strategy we should follow. And then the longer-term strategy is what I suggested earlier, creating competitive marketplaces for systems of care.
Thank you. And thank you to the panel. Can we give them a round of applause? And now we have about 5 minutes for some questions. Do we have questions from the audience? Mr. Goff.
My question is to the panel in general. One of the things we've talked about all day long is affordability. But most of the doctors that I talk to say that they're making less today than they were 20 years ago in terms of their actual real dollars. Also, many hospitals, particularly our community hospitals and our rural hospitals, are going out of business. They don't have enough money to even continue, much less to replace capital equipment and replace their facilities. Much of the consolidation that we've seen in California in the time I've been in practice for the last 33 years has been larger systems acquiring smaller community hospitals because those hospitals could not access capital in order to improve their facilities. So while I completely get the idea of the question of affordability, one of the things I'm wondering is, where is the money going? Because I don't perceive that it's going to doctors who are all getting rich and buying brand new Mercedes. And I don't really perceive it's going to the hospitals where I see them really struggling to increase and improve their ability to provide quality care. I don't have the answer, but I really think that when you get below the level of let's reduce price, you have to ask the question, where is all that money going? Is it really going to caregivers and facilities that are providing care?
I think I'd go back to a comment earlier. 30% of healthcare is wasted. So it's out there in the system. I think that's the margin, that's the opportunity for us to bend the trend, is to really tackle or focus on that so that the reward doesn't come in a fee-for-service payment, but comes in recognition of an outcome measure or a total cost of care measure. I think they're swirling, for lack of a better word, in healthcare delivery. We have to be better organized, better integrated, better managed, and I think we have to more effectively engage our patients.
I'd just add that it's everywhere. When you have a visitor from overseas and you take them around healthcare, they just see that we're flooded with money. And it's mind-boggling. We do pay doctors 50 to 80% more than most countries do, developed countries. And we pay drug companies more, and we pay clerks more, and computer programmers more. It's just everywhere. Our health system is very, very fat, and we don't have any downward pressure on it that would evenly equalize and normalize the way we spend money in healthcare. And a lot of it is waste, as Phil said, but then some of it is just price.
I'd like to add a comment from the CalPERS perspective. I agree that it's waste. There's administrative waste from just interoperational systems that don't work efficiently, whether they're human or machines. So I think that's some of the low-hanging fruit that we can look at is just administrative waste. But I think more importantly, it's volume waste. And I'm going to use the smart care example. And that is, the CalPERS team is co-chair of dealing with low back pain. So the question is surgery even indicated in low back pain? Why would a patient be admitted if they're not having surgery to take up an expensive inpatient bed? X-rays. Is an X-ray just because that's the way practice occurred 40 years ago and actually 30 years ago when I was working in a clinical practice? So it's not just waste, it's overuse or underuse or misuse, and that's part of what our drive at CalPERS is going to be about. It's about looking at value care and how we, through different mechanisms, financial and patient-driven, how do we channel or guide our members to providers who will start to pull some of the clinical waste out of the system, decide that they don't need the X-ray, send them to get an IgG, to get a hemoglobin A1C with no cost share because they're going to a specific laboratory. So to me, that's part of the efficiency, the evidence-based, and trying to reduce the amount of waste in the system.
This is a question for David. I heard you say one of the things we need to do is create some competitive markets. An idea, obviously, that I agree with. I had a recent very big disappointment, which was a few years ago. Aon Insurance Company had created a private sector exchange, contracted with Walgreens to give all of their employees each a 5-way choice of different competing health plans. And there were even projections that that is going to grow. You know, soon we'll have 40 million people. I thought, this is really great. I mean, at last. And it seems to have kind of fizzled out. And I did wonder about PBGH and thought, where are you guys? So first I had to figure out, well, why didn't it happen? And the best explanations I get are, well, employers really want to stick with self-insurance to avoid benefit mandates and premium taxes. So with exchanges, of course, you need to have insured plans so they can shift cost to the providers, shift risk to the providers. So, so it looks like that one's not going to work. So I just wonder, what do you mean when you say, oh, well, what we're going to do is move forward? I agree with, let's figure out a way to create some value for money competition. So do you have some new way of making that happen?
This is a pushing the rock up the hill problem. It's been going on for a long, long time. I think the differences between the private exchanges we saw a few years ago and what we're now talking about is this is a more care system focused approach where the care system is, as Phil has described, is bearing risk, and it's not an insurance plan with a loose network of providers that it's taking risk. The other thing is I think we're trying to do it on a geographic basis, so there's concentrated competition within a market arena. And thirdly, we have to get purchasers to agree to do it together, which is uncertain that that will actually happen. But if there's an escape valve, then it's very possible that the pressure on the market won't be effective. So, and we saw recently, those who watched the Seattle market and the Boeing ACOs, Providence announced they're no longer going to continue in that ACO model because they can. They can go back to essentially fee-for-service, filling hospital beds and do very, very well. So why should they continue to take price cuts, and Phil can maybe speak to this, in a competitive market where they don't have to? So I think a lesson from that we take anyway is if all the employers and commercial purchasers and state employee program in that market had a common contractual expectation, it would have been harder to walk away from that deal. So those are hopeful signs, but I don't expect we're going to wave the flag of victory anytime soon.
Any other? I have time for one last question. Yes.
Yeah, this is kind of like a peripheral question in a sense, but you know, there certainly is the 30% waste out there. And physicians there's just another survey done at Johns Hopkins showing that 2/3 of the doctors who were surveyed, several thousand doctors in the eastern U.S. mostly, believed that they were ordering up to 30% an increase in cost in drugs, in images, and procedures, and everything that they do because of the fear of malpractice or the fear of somehow being downgraded in terms of quality reporting. So, and I don't think the med malpractice part of it isn't the huge part of the healthcare system cost. It's 3 to 6% maybe of the total. But I think that there's a certain amount of waste there, and then there's waste administratively and across the whole prospects of it. What are the things that maybe we could realistically go after? There might be an appetite for some kinds of improvement without, the third rail things in the malpractice arena, like caps on non-economic damages or limits on attorney's fees, which aren't going to make it through the political process. So, but there are many other things we could do to reduce improve outcomes and reduce adverse events that result in malpractice issues, and relieve physicians of the concern that if they didn't order all these tests and something goes wrong, that they're liable.
So Jack, I'll take it from a pharmacy perspective. So I think physicians want to do the right thing. I'm not sure if they have the data in order to answer the right question. And so if you go into the EMR system and a doctor is writing a prescription that usually goes to e-prescribe, that goes to the retail pharmacy, or goes to home delivery, as they go through that thought process, they don't know what's covered on that plan. So actually the EMR doesn't have that. The EMR doesn't actually tell them that how much does it cost based on that plan person's design. So they don't know if that drug was $500 or it could be $5 as an alternative. They don't know if they need to do a prior auth or what the clinical acceptance. They don't know what else is on the person's prescribing patterns. And so that's when I talk about the opportunity is to solve that. So we are building a solution to that. We actually rolled out our first version of it. Our goal is to get to 50% of the market by end of next year. So our first 16,500 physicians went on the system, and it directly goes into the workflow. So they're not actually having to do anything else. It's just around how they usually use their EMR, how would it flow. We found as we've started doing it, 30% of the time when a doctor is provided an alternative, it's a lower cost alternative, they pick it. We've been able to, as part of that, as we started getting real life data, 35% of the time when they say, well, this drug has an interaction, do alternative B, or this is a type of clinical prior authorization of why it would happen, they do electronic or they avoid it. And so I think there's a lot of hope around if we actually create the right tools in order to drive those results.
I just want to add, so a couple of times in my career I've been involved in reducing variation around elective induction, C-section rates, total hips, low back pain, and more often than not, as physicians entered into a conversation and participated in a process around reducing variation and acknowledging the evidence-based standard of medicine collectively in a community, anytime somebody would reach out to their own malpractice carrier, they were wholeheartedly endorsing that as one of their strongest methods of defense, as opposed to functioning independently and just sort of shooting from the hip that maybe I need to try a little of everything.
Last words? I think that means it's time. Thank you all, and thank you for your attention.
Thank you, Kathy, John, Phil, Doug, and David. So basically, John and I are going to pull together some closing remarks. I want to thank not only the purchasing panel that are just concluding, but we had a rock star lineup today. I'd have to say we had the best of the best speakers. So out of all the summits that NCHC is probably doing, I have to say we turned out for California. So give yourself a round of applause. Thank you. And I hope, as we heard, the encouraging is that we have a lot of starts and stops in this industry, and I think Doug said it best, is we need to start actually implementing. And so I hope that You made connections in the room that maybe you hadn't made before, also reconnected to people you hadn't seen in a while, and we just need to continue this dialogue. It shouldn't be a one-time event. But I'll tell you, thank you for everyone. I'd like to also acknowledge the great people that pulled this all together, because we did this in 30 days. For everyone that was a part of the admin team, including the Citizen Hotel, if you please stand and be recognized by everyone, because we couldn't have done it without you.
Thank you, Leanne. I have three things, and then I'll let you all go. The first is to say thank you to you and your team. It's been a pleasure, and I want to acknowledge the support from my colleagues at the National Coalition. Definitely a labor of love. But this is just the second in a series of 7 that we are holding around the country of these events. So we have a lot more to go forward with. The last thing I want to say is, well, one more thank you. The Gordon and Betty Moore Foundation have made this all possible for us. And they're located here in Palo Alto, and we owe them a very deep thank you for their support. Finally, we are going to go forward from here. This is not the end. This is the beginning. We're taking what we're learning from here and other cities, and we're going to pull that all together in a report early next year, and we're going to take it to Congress, we're going to take it to the press, we're going to take it to the health policy community. And so I think there are many solid ideas here that we can go forward with, and we will be carrying those forward for you. Thank you again.
Thank you. Remember, fill out your surveys and leave them on the table for us.
Oh, sorry.